Claire Bell from West Northants Council, who's taken over from Jane, who's not very well actually today. And I've also got with me Victoria. Victoria, do you just want to introduce yourself?
Hello everybody, it's Victoria Shaw here. I am the named nurse for safeguarding adults at Northampton General Hospital.
And we should have with us as well presenting Shianne Harper-Hill, who is from Voiceability. So I'll just start with an introduction. What we want to do today is share a scenario of a complex safeguarding case that involved myself, Shianne and Victoria, and multiple other people in relation to which involved multi-agency working. The key aspects of this case were around how we worked together to try and resolve the issues that we were facing with this scenario. So what we want to do is want to share the story and give opportunities for reflection on how we worked through this case together. Next slide, Chloe. Thank you. So I'm going to introduce Bob and the circumstances that we were presented with. So the background to Bob was he was an elderly man who was living in a care home. Bob had a long-standing mental health diagnosis of dementia and previously presented with a range of aggressive and challenging behaviours. He was a widower and his wife had been known to services. They'd lived together in their own home before moving into care. Originally, they moved into care home together, but due to their own presenting needs, Bob had to move to a different care home. But the provider had supported contact between Bob and his wife. Bob also had a daughter and a grandson. There'd also been multiple safeguarding concerns raised by his family around the care that he was receiving in the care home. There had been, in the previous 8 weeks before being presented with this scenario, 11 admissions to hospital. And these admissions have been instigated by the family in consultation with the GP. And this was around their concerns about his presenting physical health and the safeguarding concerns. Next slide, Chloe. So Bob had also been subject to the deprivation of liberty safeguard since his admission to the care home. He had lacked the capacity to agree to be deprived in order to receive the care he required. Bob's family were not able to represent him as they had not met the criteria, as they had opposed to the admission to the care home and there had been previous court action. As a result of this, a paid RPR was appointed, and this role was provided by Voiceability. And Voiceability undertook regular visits and advocated for Bob. They supported the safeguarding process, ensuring that Bob was safe and the care and treatment was appropriate, and the restrictions were in his best interests. Next slide, please. Okay. So the slide here is the Gibbs reflective cycle. So I'm not sure if anybody's seen this or worked with this before. So what we're going to do, what it does is give structure to learning from the experiences. So what it's going to allow us to do is learn and plan from the things that went well or didn't go well in relation to this case. For each of the 6 stages, there are questions that guide you to reflect under each of these. So what we're going to do this morning is we're going to go through the reflective cycle. So we're going to describe what happened, what was the issues that we were facing. Then consider the feelings. What were we thinking and what were we feeling? Then what was good and bad about the experience and what sense we can make of that situation by looking at all of those things. What else could we have done? Was there anything that was amiss? And if it arose again, what would we do differently? So what we're going to do is go through this, the Gibbs reflective cycle, and we'll have opportunities where we can discuss it a little bit further as we go through. Thank you. So I'll pass over to Victoria now, who will describe what the actual situation was.
Thank you, Claire. So as Claire's previously mentioned, that was the history of Bob. And so now we're going to base ourselves into the situation that we face as the health organisation. So Bob was admitted to Northampton General Hospital. As Claire said, he'd had previously a lot of admissions in a short amount of time. And on this occasion, he presented via ambulance to our accident and emergency, and he'd had a period of all day where he'd been sleeping, he hadn't eaten, he hadn't drank. He also had low blood sugars, and when he presented to the emergency department, his blood pressure was very low and his oxygen saturations were very low as well. So on admission to our hospital, Bob appeared in very poor general health. He was very dehydrated. He appeared very malnourished. He had a large pressure sore, and he was very frail and slim and very slight man in the bed. He looked very, very unwell. As per our process, NGH raised a safeguarding referral to West Northants regarding the concerns about his malnourishment, how dehydrated he was, and his pressure sore. Which also escalated our concerns is when Bob's family came in to visit him, and they suggested that actually the care that he was receiving in the care home that he currently was placed in wasn't meeting his needs. They'd reported that he had an ulcerated throat, he was continually being fed meat products despite being a vegetarian, he had broken teeth, there was insufficient clothing available to Bob in the care home, and he also had a lot of pressure sores. So CQC also received a safeguarding notification, as did West Northants Council, regarding these concerns. So the gentleman that we were presented with at this time was very, very unwell. When we looked at his previous admissions, he had had numerous admissions over an 8-week period. I think it was 11 admissions over 8 weeks. So each time he was coming to the hospital, we were making him well enough to be discharged. However, he would then be quickly readmitted with the same concerns. When you looked at Bob, he was now 90. He was 90 years old. He wasn't eating. He had lost significant amount of weight in a short period of time, and he had reduced conscious levels. Upon speaking with the care home, they suggested that he hadn't eaten and drank because he wasn't conscious enough. And like I said, he didn't particularly wake up during his hospital admission. Late on a Friday afternoon, Bob was recognised to be within the last weeks of his life, and therefore the decision was made to put him on our dying person's pathway, which is best supportive care, to try and ensure that actually somebody who is recognised as being within the last weeks of life is given the most dignified end to their life. This was discussed within the clinical team and with the family, and it was in agreement that actually going forward, Bob shouldn't be administered further antibiotics, because actually the repeat cycle of him presenting to hospital, going through the traumatic experience of being in an ambulance, A&E, into a ward, we would then infuse him with IV antibiotics and IV fluids, and we'd get him back to a point where he was living, and he would then be returned back to the care home, and with a short amount of time he would deteriorate, and then the cycle would happen again. And actually upon discussion it felt that actually this wasn't in his best interest at this point. So the family were very, very angry about the decision to put Bob on the dying person's pathway. They were sad. They felt that we were giving up on him, and they felt that actually we were letting somebody that should still be alive die. They opposed the decision, and they came in over the weekend and strongly objected to the medics within the ward, and they suggested that the end of life pathway should be revoked. They also insisted that they had lasting power of attorney, and so the medics at that point felt very pushed and very put into a corner, and therefore they made the decision to try and recommence treatment for Bob. And at this point, IV fluids were recommenced along with antibiotics and all of his regular medication.
Turn your camera off.
Yeah.
So given the situation that we had at this time, we had to consider our next steps. So at this point, Bob had got back to a point where he was medically optimised. So the antibiotics and the fluids were starting to kick in, his medication was starting to kick in, and clinically all of his bloods and everything were improving. So the decisions that we were trying to make at this time were, where should Bob return to? Should he go back to the previous care home, given the concerns that we'd seen in front of our very own eyes in terms of being malnourished? He was very, very in poor state of health, and the concerns that family had shared. And we had to think, actually, is this care home that he's been placed in the best place to support his care needs at that point? And then we had to consider if there was a different option for Bob. Actually, should we look at him holistically, think about his care needs now, but also in the future, and start planning for the future? And then we had to consider what other options were available for Bob. And given the fact that actually he had dodged death in this respect, and we'd got him better to a state where he could be discharged, was this going to continue? And actually, should we continue to have this cycle of him being discharged and then coming back into hospital? And were there other options available for him, such as CHC fast track? And then when we think about the family dynamics, as Claire shared as well, in terms of West Northants, actually, how do we manage that? How do we manage a family that don't have very good opinions on the care home, but actually it's felt that they are maybe the best people to meet his needs at this time? So we had to consider a lot of different. So CHC fast track, so somebody is identified as being in the last 8 weeks of life, so in the dying phase of their life, that gives you the option to have a fast track discharge to a nursing home that can provide nursing care on discharge.
It stand for though, sorry.
Oh, continuing healthcare is
so it's now.
so it's C8, so it's health funded as opposed to social care funded, and it just opens those doors to people at that time, actually, to give them the best point, dignified death. So we had to consider lots of different factors at this point, and I don't know if anyone has anything that to make it a little bit more interactive that they think that actually we should have considered, or maybe were our concerns at this point about the situation that we were faced with. Oh, Carlos.
Hi. Was it the correct decision to put this chap on end of life pathway at the end of the day, since he obviously showed a recovery?
So it's a difficult one, and when we think about the dying person's pathway, whilst our palliative consultant, and I don't want to go too much into the final part and give it away, but our palliative consultant within the hospital reviewed Bob, and actually, whilst he felt that he dodged death, actually his quality of life at this point wasn't the best, and actually. Right. Sometimes the discussions that we have in terms of health is just because we can, should we? And just because we can give somebody fluids and antibiotics, should we continue to do that? So that is also something that we really had to consider at this time.
Right, just whilst the family members may have had LPA for health and welfare decisions, you can't demand a treatment, you can only refuse a treatment. So hence my question as to why the doctors then changed their perspective on their original decision.
Yeah, so I think ethically it's quite difficult to make those decisions at that time. The family had come in over the weekend when it wasn't his regular consultant, so it was the on-call junior team, and they felt very, like I said, pushed into a corner to make that decision at that time, which upon reflection wasn't the right thing to do, and we'll discuss that further on.
Can I just ask a question? This is sorry, just change. Got microphones on. Yeah, so Richard Carter here, speaking through an interpreter. We couldn't quite catch, did the family have an LPA or they didn't? No, the family didn't have LPA.
Oh, right, okay, right. Oh, that I can see with the
yeah, there'd been a previous There'd been a previous court case when Bob had first been admitted into a care home, or about 3 years later. Shianne will know better because she supported from the IMCA perspective. But no, the LPA was not with the family. The LPA was with the solicitor.
Oh, right. So,
Claire, can we just clarify that
why did they not put him in a different care home where that was clearly an issue? I mean, did they not have that as an option to move into a different care home?
Can I answer that question?
Thanks, Shianne.
So I've worked with this gentleman Bob since 2014 in the advocacy role, and there was lots of challenging, complicating factors with the family. We did a lot of best interest meetings because he lacked capacity regarding where he should reside, and actually at St Matthew's, where he did live for a substantial amount of time, it was deemed in his best interest. We fulfilled the RPR role, obviously because he was under a doles. So we were monitoring him every 6 weeks, and we had a lot of advocates supporting clients in that home. So we had a lot of eyes on. So we didn't have any concerns about how he was being cared for at this home. So that's why it was agreed that he would remain at St Matthew's until he ended up in hospital. And then we're not going to give away the next bit until we get to that bit about what happened next.
Okay,
And such
all right.
like.
Okay, all right. Sorry. Oh, yeah, carry on.
I can't see who else has got their hand up. Sorry, let me just have a little. Oh, Carlos, have you got your hand up again?
No, sorry.
Oh, okay.
I'll get rid of that.
Thank you. So thank you for that. And obviously those discussions that you're having and probably thinking in your head now are all the things that we were considering at this point. Actually, what was the option? And that's why it was so complex, and that's why we needed to call upon our other agencies to try and help us make that decision. So I'm going to hand over now to Shianne about the outcome of our decision that we made at that time, given this current situation that we were faced with.
Absolutely. And just an additional point to the previous point that was made about him residing at St Matthew's. Yes, we did go to the Court of Protection because a 21A appeal to appeal his doles was made. I attended court, the Court of Protection, and all the substantial evidence supported again that he should remain in St Matthew's, and a court order was written to support that, much to the family's dismay, because they felt that he'd been kidnapped, he was there under duress. He was being chemical coshed, but he did have enduring dementia, very high support needs, and they did effectively support his care needs, of which we observed, isn't it, and were observing regularly. So I just wanted to add that point as well. And in relation to what Victoria was saying about the clinical decisions, we were also involved as an IMCA for the serious medical treatment element of the case, because the family had very strong views and weren't actually acting appropriately. So I was involved in the multidisciplinary decisions about whether he should have treatment or not, and what was the best course of action. So we were upholding the Mental Capacity Act and working in best interest independently. So that was, again, another role that we fulfilled. And I was best placed to do that because I knew all the history of the case. And I just allocated it to a new advocate, but it was a bit too complex for them at that time. So we decided I would continue with the case, and so I did. So getting back to the outcome. So once Bob got to a particular place in hospital where he was medically fit for discharge, we were exploring whether he should return back to St Matthew's, where he'd lived for 5.5 years. And actually, the St Matthew's senior management decided that it wasn't in his best interest to come back, and they weren't willing to take him back. So we needed to explore other options about where he could kind of die with dignity somewhere that was supported in Northamptonshire. So again, it was referred to CHC fast track, and they were exploring different care homes for him. One was found in Rushden. It wasn't one that we knew in our service, so I did some research to make sure it was kind of what reputable, had good CQC standards, etc. And I did some work with the home regarding a safe transition to move there. So he was discharged safely there through the CHC fast track, and on the day I spoke to the staff and the manager of the new care home, and obviously they accepted him later that afternoon, isn't it, Rich? Which was a a positive, safe discharge. And then I continued to support him once other professionals were no longer involved because of their their pieces of work had finished at the hospital. We carried on fulfilling the RPR role under his doles, and I was shielding at the time, so one of my advocates went to visit him in person as well. So that was really positive. He settled quite well. The home got to know him quickly, and I'd obviously discussed the issues we'd had with this the family. So they put some protective measures in place to support the visits while he was at the end of his life. And so I think he stayed there for nearly 3 weeks before he passed away. But he did die with dignity, and it was it was quite peaceful. And he'd got to know 3 particular staff he responded really well to, which was really, really positive. And I think our relationships with the home built, and I think I was speaking to them every single day, which was positive as well, because it was a home we didn't know. So that was really good. And so he passed away peacefully. There was no further issues with the family at that point, but we had significant issues ever since I first had the case, really. Since 2014, they did not want us involved. As much as we tried to explain our role, that we were independent oversight, and we were kind of as well as them, but making sure he wasn't lost in the process, making sure he got supported as he wanted to be supported, and it was it was effective for him. There was a lot of difficulties both throughout the whole case and in court as well. So there was definitely value to having advocacy involved, isn't it, really? Again, to make sure he wasn't lost, because the family dynamics seemed to override lots of decisions and lots of the care he was receiving, and unfounded. Many safeguardings were submitted over the years, and they were all unsubstantiated, because we were able to provide the independent oversight that we weren't concerned, because we'd be raising them ourselves if we were, if we were concerned. So that was really positive. So, is there any questions from that? Can't see any hands up at the moment.
So Richard's was saying, wow, what a difficult, complex case. And especially as you've got family dynamics like that, where you're at conflict with them and with the decision making, that really does make it so much harder, doesn't it?
Really,
and
it really
it's really important that you had that independent advocacy. Obviously, I can see how clearly there that how important that was.
Thank you. No, it was a challenging case, but I think what we take away from this, it was some excellent collaborative work in really key positive communication to keep each other up to date. I was saying, I think I spoke to Victoria every day for 6 weeks, isn't it? And I'm speaking regularly to Claire as well, and most people that were involved. Meetings were pulled together at really short notice on Teams, and everybody made valuable contributions, making sure that Bob was central to all decision making, and that everything was, we were working in accordance with the law, really. So that was really positive as well.
Yeah, communication is key. Absolutely, always is.
So I think what we were saying, it is about reflecting on that. It was very complex. It was very, as we were saying, we were having numerous meetings at a very fast pace. And as Sian said, it was so important to keep Bob at the sort of centre of all of these discussions and not lose it. As you can see, there was a lot of legal complexities in relation to the deprivation of liberty. There was a lot of best interest decision making in relation to the end of life care. And there was that large number of professionals that were involved. So along, the General Hospital, Victoria and her safeguarding lead were the ward staff, the palliative care, the ward consultant, obviously the previous care home manager and staff, who did support that decision making about whether it was in Bob's best interest to return due to the physical health deterioration and whether they were best placed. West Northants Council, so we had the principal social worker guide us through, myself as the safeguarding lead, and the BIA, who was supporting all of the deprivation of liberty work that was required, and obviously voiceability is the RPR. And I think when we reflect back on our feelings, you know, as a group, we were anxious that the views of the family may impede Bob's opportunity to have a good and dignified death, but also recognising that they were his family. So from a legal perspective, we were having to support the decision making, but actually they were his family, and we recognised that this was the end of his life. And that we had to be think about our professional feelings and dealing with the legal aspects of this, but not forgetting that Bob was actually central to this. And whilst the family were challenging, and there were other challenges along the way, that actually we had to put that aside, those feelings. We were upset that our time was being spent defending our actions rather than being able to sit down and develop that really good end-of-life care plan for Bob. And also, if we're going to be honest, whenever we get a challenge, we do feel professionally challenged, and it does then make us think slightly differently. And Victoria reflected on the ward staff and the challenge from the family initially around the end of life, and that did make people consider other options, but it was also that professional challenge. And so as a group, I think that the support that we gave each other from a multidisciplinary perspective, and it wasn't just those professionals, we had the ICB support us in relation to the GP, who again, when Bob was in...
What's ICB?
Sorry, Integrated Care Board, ex-CCG, Commissioning Care Group.
Oh, got you. Right, yes. Sorry, carry on.
No problem. Who supported us in relation to the safeguarding concerns and also around the GP, because the GP was being challenged every time to admit Bob into hospital. So, you know, on reflection, there was a lot of feelings that we had, as well as obviously from the family perspective. Victoria, Shian, do you want to add anything else in on that?
I was just thinking, Claire, about how the medical point of view, I think, was so important here, that actually the recognition that this man was dying and was within the last 8 weeks of his life, and also that I know that our palliative consultant made quite a statement during one of our meetings, and also to the family as well, that actually Bob's condition wasn't a consequence of neglect. It was actually a direct correlation of a man who was in the last weeks of life and a dying man. And I think that is such an imperative point of this story, that actually what was the best thing for Bob at this point. And as I said earlier, you know, just because we can, should we continue to keep trying to save this man who in the eyes of medics is dying? So how do we best support that? And I think that with Shian being involved as well, absolutely an amazing piece of work that kept Bob in the centre of every decision that we made. And whilst we may have been sidetracked at times, and whilst the medics may have been sidetracked and recommenced him on the end of life pathway, actually when we drew it back and within a short period of time, actually Bob, when we considered Bob, actually all the decisions that we made were always in his best interest at that time. And I just think that without one another, the outcome would have been probably very different. And that's why it's just so important that we celebrate that in that respect.
Yeah, absolutely. And I think following on from what you've just said, Victoria, as well, isn't it? I think, like you say, keeping Bob central to all the decision making, and I think because he was non-verbal, he was never able to express what his wishes were. The fact he's had 11 hospital admissions in 8 weeks, and obviously he'd always struggled to access hospital and found it difficult, you know, with the environment and with his dementia and such like. So again, we're trying to take into account what might he want, you know, what you know, and having to have all this medical treatment each time he came in, and obviously deteriorating each time. And it was certainly an ethical dilemma for me as well, you know, the right to life, the right to treatment, and coming from that premise. But actually, when you're hearing what consultants are saying, it would be likely to be futile, but he deserves to die with dignity, obviously. So we were coming from that premise, but equally trying to put ourselves in his shoes as well, isn't it? Regardless of what the family was saying. But equally, we were compassionate to the family's views, like Claire said. We were all very empathetic towards them, despite the hostility they kind of expressed towards us. I say especially to myself, because I've had since 2014 of them not wanting me to be involved and kind of slating my character in court and things. But again, it wasn't about them, it was about Bob and obviously what Bob wanted and what was right for him. So we made sure that we protected his rights, and all decision making was kind of in his best interest. So again, it was a privilege to be involved in this, and like Victoria says, you know, an amazing piece of work to be celebrated, how we brought so many professionals together around a really vulnerable individual to ensure he had the medical treatment he needed and then a dignified death. So yeah, it's a case that will always stay with me.
Jan, why were you involved since 2014?
Because well, initially we got involved with the safeguarding back in 2014 because he lived at home with his family, and basically he wasn't receiving any care, and he lived with his wife, and she was also quite unwell, and he was preventing her having care. So we were involved in looking at exploring care for them both to move into a care home together. So they did move into a care home together. I can't remember. It's the north of the county. I can't remember the care home. But so they lived together. The old vicarage. That's it. The old vicarage. They lived together in a shared room. And then obviously his wife deteriorated quite significantly and sadly passed away. He then moved to St Matthew's, and we were involved in that move. And then throughout all the years following that, he was under an RP. He was under a DOLS. So we were appointed as an RPR following this referral, so that we could protect his rights under the Mental Capacity Act for his DOLS, and remained involved for each authorisation until he passed away. So yeah, it was either accommodation moving, or it was the RPR in relation to his DOLS, or it was safeguarding, and that the safeguarding was quite pivotal all the way through. I worked together since 2014. The family put in a lot of safeguardings, so we were involved in all those investigations, making sure that his views were tried to be ascertained, and and actually to counter some of the concerns that have been raised and the allegations, because they were very unfounded. So yeah, so that's our involvement really.
Lovely, thank you.
Can I ask a couple of questions? I'm sorry, I can't get my camera to work, by the way. The first one is, I kind of can anticipate what you're going to say to this, but if you're saying that you've been involved since 2014, I'm just wondering why the care home, there was no sort of plan or anything put in place for him in the event of this sort of thing happening, because obviously dementia is going to deteriorate, isn't he? So
absolutely, I think we've raised this as a small team as well, discussing this as well, and I think because I think the family had very strong views about what they wanted for him, and I think on reflection we would discuss with the homes something very different to what not disclude them, but basically have something about what would be best for him, because it was very difficult at that time to kind of execute a plan that was that didn't exist. We had to formulate one very quickly. And I think,
question, why? I'm struggling to understand why earlier on, and this the care home hadn't sort of formulated some kind of a plan as to, well, if and when we get to this scenario, what are his wishes and what should we do? And the other question I just wanted to ask was, obviously this was incredibly difficult for the family as well, and I just wondered what if they had access to, if they were offered any kind of support or counselling, to help them deal with their feelings about this as well.
Yeah, sorry.
No, I was just going to say, Shan, about the care home. So the care home would have, and I'm sure she had, a plan around end of life, and should this scenario occur. And there was sort of quite a robust care plans in place, would you say? Because obviously we had to do that around, or the care home had to do that around supporting visits. But the visits could be quite complex as well by the family, so there was sort of quite robust plans in place about how they could facilitate that. So the plans are in place, but as we were saying earlier, I think the issue that arose, and one of the issues was that the family were going directly to the GP, and the GP was then facilitating either an ambulance or an admission into hospital, as opposed to the care home. So I think there was a lot of other complexities within the care home around how they should be supporting Bob at this stage of life. And actually, you know, I think the care home would have said that actually if they could have had the physical health support delivered into the care home, that would have been the best case scenario. But we had this added complication that the family were ringing ambulances because they felt that he needed to go into hospital at that moment in time. And I think this last scenario was the one where we really had to stop and reflect and think, is this the best way to go in relation to that? So I hope that sort of helps with that.
And I think following on from that, I think that influenced the decision about whether he should return to St Matthew's, didn't it? You know what I mean? Because of the issues with the family and what they were having to try and manage. You know, I think that really did influence the decision for him not to return there and for us to explore somewhere new. Because I was certainly advocating that he would go back there because it was familiar to him. He knew the staff. You know, he responded well to them. He'd been there for 5.5 years, but that was a management decision in St Matthew's that they made, which we can completely understand because it was extremely challenging to manage the dynamics with the family, and especially at such a critical time that was very distressing for them. And as to your question about whether they offered any support, they were offered to speak to people at Northamptonshire Carers, but they declined. They were offered to talk to someone else a few years ago as well, and they declined. They didn't want anyone else involved. They didn't want to talk to anybody, and we were all trying to be quite supportive to them, but that seemed to fall on deaf ears and aggravate them. So you know, we just supported them the best we could, but it was actually about Bob, so we were making sure our focus was on Bob, really.
Yeah, of course, but you know, I'm just saying that it was obviously, the family would have obviously been very distressed about all of this. I'm not, you know, it was clearly the right decision for as far as Bob's concerned. I'm still not sure as to why. I'm assuming that he lacked the capacity from the word go at the care home, but I would have assumed that there would have been something in place which were Bob's wishes, and given that the family didn't have lasting power of attorney, then obviously you have to follow his wishes, even though it may be totally different to the family's.
Absolutely, and I think like we say, because he was non-verbal, his dementia progressed quite quickly over the years. It was very difficult to ascertain his views. We knew he didn't like being on his own, so obviously the staff made sure that there was someone holding his hand towards the end. I knew that was would have been one of his wishes, you know. But he was quite a proud personal man, you know, proud man as well. And I didn't really feel from the interactions he had with his family that would be, you know, that would I thought that caused them some distress, whilst they had a right to spend some time with him. You know, actually we wanted it to be peaceful for him from what he'd been through. So again, that was handed over to the care home, and they did manage it, you know, really well. They did manage the whole situation really well for a home that didn't know, you know, all the history and everything that's happened. And kind of on their own as well, because obviously other professionals had kind of withdrew. So that was, they did manage it really well. And like I say, I had contact with them every day, isn't it? They kept me updated, and if there was challenges with the family, they discussed it with me. So we had a plan to support the family and support them. So
were there any family members there when he died?
No, they'd been in the morning, and then they'd gone home, and then obviously were coming back. So it was in that period in the middle.
He died away. In the middle. Okay.
Basically,
there was no one stopping them being with him, and you know, when he died, it was just what happened, basically.
Yeah, just the logistics of it. I mean, they kept it quite open-ended, that they were, you know, the grandson was able to visit quite freely and spend time, but they were aware of, you know, the issues that could present. So actually there was people around to keep an eye, do you know what I mean? Sort of not actually with more time, but to keep an eye in case something did present, to prevent it. And
do you think this family were aggressive?
They could be very
verbally aggressive.
Yeah, there was a lot of verbal aggression from the family, and this had been going on for as long as we were involved with Bob and his wife.
And I think for me, I was quite a trigger for them, because I was, independent, and as much as I was as well as them, you know what I mean, and always tried to kind of they would try to include them in things, and make sure it was solely about Bob. It antagonized them, so it made it very difficult. But again, we just kept the focus on Bob, and we've been instructed to do this piece of work in accordance with the law, so that's what we're going to do. And then we just had to deal with the fallout with other professionals involved, so that's what we did. So it made the piece of work very, very challenging over the years.
But also, just to add, sort of from my point of view, throughout his whole hospital admission and his discharge, the family were never restricted from seeing him. We always kept the family very involved, and whilst we took into consideration their viewpoints, whilst they weren't medically the best in Bob's best interest, we still considered them and supported them when actually we did go against what they thought, and explain why. I built up quite a good relationship with his grandson at this point, and sort of became the point of contact. And because whilst the decisions he was making weren't in Bob's best interest, he felt that they were, so we always considered that and ensured that he understood where we were coming from. And he continually visited Bob. It had open visiting on the ward, he could come whenever. So we did support the family in that respect as well, and didn't segregate them, even though they did have their LPA revoked. It was central. They were central to a lot of the decisions and part of those decisions, and just made sure they were fully informed throughout the whole process.
And just to add that, obviously, when he was in the care home, he was under deprivation of liberty. When he was admitted into hospital, we undertook another authorisation. And as part of that, the important part of that is also consulting with family members. So family members were consulted under both of those dolls, or all of those dolls, because obviously we then had to do another deprivation of liberty when Bob was finally moved to Rushden. So all of that would have involved consultation with the family. Should we move to the next slide? Because I can see time's flying away, I'm afraid. So thinking about that reflective model, obviously the thing is that we do have to consider is and evaluate is what did go well and what didn't. And we're not saying this was a perfect case scenario. So we had to sort of sit there and evaluate what was good, but what wasn't quite so good. So I think, as we said, it was great collaborative work, and there was quite a number of people involved, and when there's that number of people involved with all of the different roles, you can lose people. But I think Bob stayed sort of at the forefront, and making sure that we got the right people in the meetings to make the decisions. So it wasn't being done in isolation. And we considered everything. As I said, Bob was central to all decisions, regardless of every other issue and aspect of this. And the care home had agreed to him leaving without notice, because they felt that was in his best interest. As you are aware, Voiceability remained involved due to their long-term involvement, and that positive and the understanding of Bob and the relationship with Voiceability. As Victoria said, the consultant was clear in his diagnosis and prognosis and the care plan. And, it was very positive conversations were had. And I think adding to that, and I think we mentioned it when we were talking, is about that openness and honesty. So whilst there may be conflicting views, we were very open, we were very honest about the presenting concerns. And I think all the way through it is that consideration that we had to maintain his legal rights. He was subject to the framework of DOLS, NGH, and then on the care home. And actually, we maintained those legal rights, and we followed that legal process to support Bob. I think from a sort of what wasn't so good, I think, Victoria, do you want to talk about what wasn't so good?
Yeah, so I know I've previously mentioned it. So when the family came in at that point and said that they wanted treatment to be recommenced and they had lasting power of attorney, from our side, we didn't check that validity and we took it at face value and we did commence treatment. Arguably, that wasn't in Bob's best interest, LPA or no LPA. However, they didn't check the validity at that point. And then there was an initial lack of understanding of the full picture that led Bob into hospital at that time. However, once that was understood and then the multi-agency working came together, then that's when actually that picture and that jigsaw puzzle that safeguarding is became a lot clearer and the plan then changed. And also what wasn't great as well is that our ward staff were diverted in terms of the family dynamics, and actually sometimes they did forget about Bob. Again, it wasn't a long period of time, but I think that it's just important to acknowledge that it is a human nature sometimes as well when you're getting that interference from other people. There was also one day on the ward where the police turned up on the ward, CID turned up with the family, suggesting that actually there was high levels of neglect. And I know we discussed this previously in terms of me, Claire and Shannon. I actually took the police to see Bob at that point. Again, I wasn't sure how best to deal with it, but actually this was a dying man. And I think sometimes to see somebody in that state is actually a lot clearer than anything that words can say. And that was the decision that we made. But I think, and I don't think it's just NGH, I think it's probably all of us do have the unconscious bias at times, but also when family are interfering, that can take the focus off of the patient or of the client. So that did happen, unfortunately, at the start, but once we refocused, actually Bob was kept central to all the decisions that we made.
So can I ask, who was the did you have any involvement with VPO, which is vulnerable person? No, what's it? VPO with the police. Don't they have a VPO who deals with vulnerable people and safeguarding? Do you have anything like that locally here in Northampton? Were they involved?
We do have a safeguarding department within Northamptonshire Police who were involved to give obviously their viewpoint in terms of a police point of view. We do have a vulnerable adults group within the police here, yeah.
Oh, that's good. Yeah, that's it. Vulnerable adult. Yeah. Yeah. I can't remember if it was a VPO, but vulnerable person officer, I thought they were called. But anyway, thank you. Carry on.
Okay, so obviously that was sort of the description, so part of that reflective model about, you know, what was it that we were facing, what were our feelings, what's our reflection about what went well and what didn't go well. And then part of that reflective model is then analysing all of that information and thinking, why did that happen? Why didn't things go quite so well? Why did they go well? And now you've had a chance to sort of listen to the story, is just share your thoughts on what you think could have been done better or changed, and how the outcome could have been changed. Have you got any thoughts at all?
No, it sounds to me it's so complex, the case, that you did the best. You know, I think you dealt with it well, really, from what I can see, bearing it all in mind.
Thank you.
Welcome.
I'm going
Thank
to
you.
play devil's advocate and repeat what I said before, that really that's you know, I think what's come out is that checking that when somebody says they've got lasting power of attorney, they do actually have the documentation to back it up at the earliest convenience.
You'll be pleased to see our last slide then. So well done, you get the brownie point. Okay, next slide. So our analysis of the situation and looking at the facts here are, you know, Bob's original needs were being met at the care home. Bob's rights were safeguarded via that legal process of doles. Bob's care plan was proportionate to his needs at the care home. And when Bob's health changed, the interested parties had to make a best interest decision about how best he should care for. This was challenged by allegations from the family, which upset the ward staff and actually interfered with his care. So that initial, as Victoria was explaining about, you know, around the situation they were faced with. What they had got was somebody who had been admitted to hospital, and as Victoria described, with sort of quite serious physical deterioration. And that sort of first look at that person would have shocked the ward staff quite with that, and then the allegations from the family. But it's looking past that. The overarching need to create a plan that worked in his best interests. The medical team, as we said, were very open and honest, admitted when all support had been offered and attempted before recognising his end-of-life status. So they did work through all of the scenario before recognising and listened to family before recognising the end-of-life status. And actually, the outcome at the end was that he moved to a care setting, which was specialist in end-of-life care. So just saying, I think the lady who mentioned what I did at the previous care home, was it not necessarily the best care home for him to return to, would be he was admitted there with due to behaviours that were challenging. Around his mental health, but actually what we needed at this moment in time was a care setting that was specialist around that physical end-of-life support. The family wanted a new provider, and actually we listened to that at the end of life. The current provider stepped aside to enable us to do this, and prior to his move, his rights were managed using doles in the hospital. So sort of that was our analysis of this situation. Next slide. So Shan, do you want to do the last slide about the learning?
Sorry, I was on mute. Sorry. How many times do we say that on Teams? So yeah, so about knowing the family better, isn't it? And like we said, firstly, it was about, you know, the proof of them being lasting power of attorney. That I say that's some learning that's taken away from this and for future cases, and also the better end of life planning, as some people have raised today, actually, and making sure that whilst we take into account their views as a family, also what would he want, what would Bob want, isn't it really, and making sure that's recorded. So we've taken that on board on cases of a similar nature at the moment, isn't it, and doing some more intensive work about obtaining people's views, even if they're non-verbal or have communication issues. So that's something we've taken on board, and talk to Bob about his own end of life plan. That would be a piece of work in itself that was done prior to. So that is something, again, we take away and then would be shared, and we would do that in collaboration with the care home as well. And as we said about the police, the vulnerable team in the police, isn't it? Make sure we include them in our discussions right at the beginning, and obviously give them the context about the family, because I think if they've got that, then actually that could have made this case run a bit smoother than it did, isn't it, if we'd have involved them earlier on. But actually, again, isn't it, the allegations that they were making and the fact they brought the CID in on that weekend, isn't it, which Victoria had to sort of deal with. I think, again, they didn't have context on that day, but then to visually see Bob in a dying man in his bed, that really put things in perspective for them, didn't it, and kind of helped them to understand what was going on with this situation. So and also, if the police were involved, that would help us to anticipate some of the allegations and help manage them. So I think that was definitely some learning we would take from this case, isn't it, and use in other cases, definitely. Yeah. So
anybody got any other thoughts at all?
No.
So I think sort of from us in conclusion, we felt that by working together as that multidisciplinary team, having the right people in the room to make those decisions, being very open and honest. And I think sometimes we're scared about doing that because of the confrontation. But keeping Bob at the forefront of all of the discussions, protecting his legal rights, that this actually supported us to make a positive outcome, and Bob actually had a more positive outcome at end of life. Is there anything else, Victoria and Shian?
Not from me, thank you. Here's the NSAB information page if it's of use to anybody. If you need any information, then that's their website. Give them a follow on Twitter, and then also there's a copy here for your evaluation form, but I believe Chloe has also sent that out to everybody. If you could complete that for the session that you've or to just pop something in the chat, just for the session that you've completed this morning, give some honest feedback to us, and then you can receive a certificate for your attendance.
Okay, thank you.
And happy to take any questions or anything that anybody wishes to ask.
It's not a question. I just want to make sure, not certain if people can hear me, about the lasting power of attorney. I think we need to be aware there are two lasting powers of attorney. The health and welfare and the finances. And sometimes families, with all the best will in the world, can get a little confused and think they have the lasting power of attorney when they've for health and welfare when they've only got the finance ones.
Yeah, that's very true. Yeah, that's something that in healthcare that we see quite often, actually, in terms of an acute trust. Sometimes people say we've got lasting power of attorney, they bring the document in, and actually it's for finance. Again, their viewpoint is still very valid and we take it into consideration, but it's something that people don't always realise, do they, in the best will in the world, but actually they've got the wrong form.
And I'll just feed Carol Anna, who's just spoken, because Carol Ann was actually the BIA who undertook all of the best interest assessments. So Carol Ann was really pivotal to this work as well. So she's listened. Hopefully I've done a good job for her.
Oh, thank you, Carol Ann.
I think it was a very, very difficult, very complex and very, very challenging case. And I think for me as well, because normally we would not go and assess people in hospital on end of life care, but obviously because of the complexities with the family dynamics, we absolutely had to. And I have to admit, it was an absolute shock for me, having proved when I saw Bob lying when I saw Bob, lying in his hospital bed, looking, so frail. If I was to tell you, for example, if you think about between your collarbone and your shoulder, you could have there was almost like a hollow there. You could have literally put your fist in that hollow. He was so frail, whereas previously, he'd been a very strong, well built man. But it was for that situation, that was absolutely the right decision to do. And I think what we tried to do, that both myself and the Dole's doctor, we went together to try to minimise, any distress to Bob, and because he was non-verbal, we absolutely kept the capacity assessment, to an absolute minimum. Clearly, it was challenging consulting with the family, but that was having previously been involved. That was something that I expected. And I think the sad thing was that his grandson really did think, that with treatment, Bob will get better to the extent that Bob will be able, to physically, walk again. Whereas, he hadn't been able to weight bear or walk for years.
Yeah. So can I ask, with the Doles, and that, does Doles get replaced by LPA? Oh, sorry, LPS. Did it get to liberty protection safeguarding? So will that change, do you think, going forward?
Well, clearly when the liberty protection safeguards come into place, what it will mean is that DOLS at the moment only applies to care homes and hospitals and to people over the age of 18. So when LPS comes into place, it will apply to a wide range of settings, supported accommodation, people's own homes, people over the age of 16.
Oh, right, yes, it'd be quite different, won't it? So it'd be quite a big. We are all going to need a lot of training on that, then, aren't we?
Yes,
absolutely.
Unfortunately so.
Yeah. Okay.
Helen, have you got your hand up?
I have. I just wanted, I'm busy typing it, but I can say it now. I am employed by Northamptonshire Carers to work as part of the recently created Ageing Well team that work across Northamptonshire. And what I think I'm taking away from this training today is when we go out to do our pre-visits to our referred people, whether it might be helpful and appropriate for us to ask whether there is sort of like whether the patient has got certain wishes in place and whether there is that plan already there. And also one question we do ask is there anybody there with lasting power of attorney in the family? And I'm wondering now whether we could take copies of those documents, obviously with those family members' permission, which it's a question we ask, and whether, because the work we do is uploaded onto something called System 1 and forms part of their personal care and support plan, those documents could then be uploaded to that and you'd have access to them anyway.
So unfortunately, we don't have access to System 1 in the hospital at the moment. It's something that we're trying to address because obviously it's just the absolute information. It's got so much information there.
It does have a lot of information.
Which unfortunately we are not privy to a lot of the time. But it is something that we're looking into. And in terms of LPA, we do ask for a copy and then we take a copy. We never take the original document. Just in case it gets lost, because things do go missing, don't they, when they're paperwork. But really good, Helen, asking those questions. And whilst sometimes people feel uncomfortable at times to have those conversations, they're very necessary. And actually
it isn't an easy conversation to have.
No,
but we're
it's
going
not.
in to see people who are very frail, who've got frequent admissions into hospitals, and obviously the whole point is to prevent those frequent admissions. And
of course,
and some people, I find some of my patients actually want to discuss it, and the family members find that difficult.
Yeah, and I think that so from my point of view, and I think when you reflect on this kind of situation, actually having that information is absolutely amazing. And then we know that we're doing what that person would want. When you think of past wishes and feelings and taking that person into consideration, even when they're lacking capacity, we think of the Mental Capacity Act. Actually, it's like gold dust, isn't it? Because you know that you're doing the right thing at that point. So absolutely, I would advocate having those conversations.
Really, before it gets to that stage, and
yeah,
exactly the work that we do. Brilliant. Yeah. Okay, thanks.
Thank you, Helen. Carlos.
Just following on from that previous comment, you can search the Office of Public Guardians register to find out if there's an LPA and it's probably doing that. It's probably wise because it gives you the up-to-date situation. Because sometimes LPA disappear or change.
Yeah, and it comes through within a few days often, doesn't it, when I do it? So it's very quick response.
Yeah,
which is great. Yeah.
And the other thing, it's not always just one person. So you can have multiple people who are LPAs. Carlos knows what I'm going to say, and if you have more than one person and they have conflicting decisions, but they've both got LPA, you're in a different ball game again, because they've both got the same rights to make the decision, and the decisions they're making are different. So yeah, LPA is very, very good, but there are still some anomalies there as well.
Has anyone got any other questions or anything they want to ask? Thank you all for being so engaging. Hopefully you've taken something from it. Like I said, if you can fill that evaluation form in for us, that would be great, and then you can get a certificate for your attendance. And thank you also to Shian and Claire, and thank you for everybody that was involved in this case. Really complex, but actually a really, really good piece of work.
Well done.
Thank you, everybody.
Thanks.
Yeah.